Pulmonary tuberculosis Part 1. Dr. Jalal Mohsin Uddin, Associate Professor, National Institute of Diseases of Chest and Hospital. Topics: Pathogenesis of PTB, Clinical Features, Diagnosis. Introduction. Despite being a preventable and curable disease, 1.5 million people die from TB each year, making it the world's top infectious killer. About half of all people with TB can be found in 8 countries: Bangladesh, China, India, Indonesia, Nigeria, Pakistan, Philippines, and South Africa. People infected with TB bacteria have a 5 to 10% lifetime risk of falling ill with TB. Despite being a top 10 global causes of death in 2021. 1. Ischemic heart disease. 2. COVID-19. 3. Stroke. 4. Chronic obstructive pulmonary disease. 5. Lower respiratory infections. 6. Trachea, bronchus, lung cancers. 7. Alzheimer's disease and other dementias. 8. Diabetes mellitus. 9. Kidney diseases. 10. Tuberculosis. In 2022, the countries with the highest number of tuberculosis TB cases were: India, 27% of global TB cases; Indonesia, 10% of global TB cases; China, 7.1% of global TB cases; Philippines, 7% of global TB cases; Pakistan, 5.7% of global TB cases; Nigeria, 4.5% of global TB cases; Bangladesh, 3.6% of global TB cases; Democratic Republic of the Congo, 3% of global TB cases. Steps of pathogenesis. Transmission. Inhaling the bacteria. Immune response. Multiplication. Latent infection. Reactivation. Etiology. Tuberculosis is caused by Mycobacterium tuberculosis, which is also known as tubercle bacilli. Other mycobacteria that can cause human tuberculosis disease include M. bovis, M. africanum, M. microti, and M. conneti. Microbiology of Mycobacterium tuberculosis. These are acid-fast bacilli. These are rods shape and grow in cords. The growth is very slow on special media. They get gram stain but are very weak, which is gram stain positive. These are non-motile, obligatory aerobes, and intracellular organisms. Humans are the only reservoir. Transmission. Mycobacterium tuberculosis, or TB, is transmitted through the air when a person with active TB in their lungs, larynx, or airway coughs, sneezes, speaks, or sings. The bacteria are contained in droplet nuclei that can remain suspended in the air for hours, depending on the environment. These droplet nuclei are about 1 to 5 microns in diameter, less than 1/5000th of an inch. TB germs are more likely to spread in indoor areas or other places with poor air circulation, such as a closed vehicle, than in outdoor areas. Transmission of TB is by inhalation of infectious droplet nuclei containing viable bacilli. Aerosol spread. High-efficiency particulate air HEPA filters can be used to help prevent the spread of tuberculosis TB by removing infectious organisms from the air. MTB is released into the environment through feces, urine, aerosols, and sputum from infected individuals. It is resistant to drying, alkaline, and acid conditions. UV light and high temperatures from sunlight can kill MTB. To prevent the spread of TB bacteria, we can ensure good ventilation. Exposed to natural light. Practice good hygiene, such as covering our mouth and nose when coughing or sneezing. Factors influencing transmission. Bacillary load of the source case sputum smear positive or lung cavities on chest radiograph. Proximity and duration of exposure. The risk of infection among household contacts of TB patients is 30%. The best way to stop transmission is to isolate infectious persons and to start giving them the standard TB treatment as soon as possible. Transmission is dramatically and rapidly reduced with effective treatment. Not everyone who is exposed to an infectious TB patient becomes infected with tuberculosis. The probability that TB will be transmitted depends on 4 factors: infectiousness of the TB patient, environment in which the exposure occurred, frequency and duration of the exposure, susceptibility immune status of the exposed individual. Persons who spend a lot of time in enclosed spaces with people who have infectious TB disease are the most likely to be infected with tuberculosis. These persons, or contacts, may include family members, friends, roommates. TB germs are not spread by shaking someone's hand, sharing food or drink, touching bed linens or toilet seats, sharing toothbrushes, kissing. One of the following outcomes may happen after transmission. After being exposed to Mycobacterium tuberculosis, the bacteria can settle in the lungs and cause a variety of outcomes depending on the body's immune response. Latent TB, the immune system contains the bacteria, and the person doesn't feel sick or have symptoms. This is also known as latent TB infection. Without treatment, the bacteria can become active at any time. Active TB, the immune system is unable to stop the bacteria from multiplying, and the person becomes sick. Symptoms include a cough, chest pain, fever, chills, and weight loss. Active TB can be fatal if left untreated. No infection, the body's immune system kills all the bacteria. The majority of individuals infected with tuberculosis, 90%, do not develop disease. Who are at risk of development of active tuberculosis? People with weakened immune systems are at high risk of developing pulmonary tuberculosis (TB). 1. HIV. People living with HIV are at high risk of developing TB. 2. Medications. People taking immunosuppressive therapies, such as corticosteroids or TNF antagonists, etanercept, infliximab, are at high risk. 3. Chronic health conditions. People with CKD, diabetes, leukemia, or cancer of the head, neck, or lung are at high risk. 4. Organ transplants. People who have had an organ transplant are at high risk. 5. Substance use. People who inject drugs are at high risk. 6. Age. Children younger than 5 years of age and older adults are at high risk. 7. Recent infection. People who have been infected with TB within the last 2 years are at high risk. 8. History of TB. People who have had TB in the past, whether treated or not, are at high risk. 9. Low body weight. People who weigh less than 90% of their ideal body weight are at high risk. 10. Indoor air pollution. People exposed to biomass smoke from cooking are at high risk. 11. Smoking. Smoking can impair the immune system's ability to fight TB. The 3 stages of TB are: primary infection, latent TB infection, active TB disease, host organism interaction. The clinical manifestations of tuberculosis represent a complex interaction between the causative organism, Mycobacterium tuberculosis, and the human host immune response. When a person inhales air that contains droplet nuclei containing tuberculosis, most of the larger droplets become lodged in the upper respiratory tract, the nose and throat, where infection is unlikely to develop. However, smaller droplet nuclei may reach the alveoli, where infection may begin. In the alveoli, some of the tubercle bacilli are killed, but a few multiply in the alveoli and enter the lymph nodes and bloodstream and spread throughout the body. Bacilli may reach any part of the body, including areas where TB disease is more likely to develop. These areas include the upper portions of the lungs, as well as the kidneys, the brain, and bone. Within 2 to 8 weeks, however, the body's immune system usually intervenes, halting multiplication and preventing further spread. At this point, the person has latent TB infection (LTBI). Flowchart of pathogenesis of tuberculosis. The innate immune response. The key players in the innate defense against tuberculosis are the alveolar macrophages and dendritic cells. Macrophages, dendritic cells, and other immune cells recognize mycobacterial structures, with membrane-associated pattern recognition receptors (PRRs). The innate immune response continue. PRR-mediated phagocytosis of the pathogen by macrophages is an essential feature of the innate immune response. Ingested bacteria are then destroyed through phagosome-lysosome fusion and acidification. Immune response mediated through macrophages can have 3 major results: 1. Cell necrosis, 2. Apoptosis, 3. Survival of the infected macrophages. If the cell undergoes necrosis, mycobacteria are released and may infect new macrophages or disseminate, whereas an apoptotic cell membrane is not compromised and the bacteria are destroyed with the macrophage. Survival of infected macrophages enables the mycobacteria to persist and even proliferate before the adaptive immune response is activated by specific T cells that have been selected in the regional lymph nodes, generally 2 to 3 weeks after primary infection. Gon complex. Primary necrotic lesion formed by Mycobacterium tuberculosis is known as a Gon focus. TB infection can also spread to nearby hilar lymph nodes, either carried through the lymph or by direct extension of the Gon focus. Together, the casating tissue and associated lymph node involvement make up the characteristic Gon complex. A Gon focus is usually found in the upper part of the lower lobe or the lower part of the upper lobe of either lung. A Gon focus is a small area of granulomatous inflammation that's usually not visible on a chest X-ray. However, it may become visible if it calcifies or grows large enough. The adaptive immune response. Dendritic cells are an important mediator between the innate and adaptive immune response, which, in addition to phagocytosis, present live mycobacteria to naive T cells after migrating to regional lymph nodes. After antigen presentation in lymph nodes, CD4+ T cells are activated, and migrate to the lungs to impede mycobacterial progressive growth. The adaptive immune response continue. The crucial role of T cells in immunity to mycobacteria is evidenced by the dramatically increased susceptibility of individuals with HIV infection. Susceptibility to TB increases as the CD4 cell count decreases. IFN gamma, produced by activated T cells, has a crucial role in protection against TB that is intracellular mycobacterial killing. The IFN gamma release assay IGRA is a blood test that can detect TB infection, even when a person doesn't have symptoms. TNF-alpha is another key cytokine produced by macrophages, dendritic cells, and T cells and plays a central role in granuloma formation, macrophage induction, and has immunoregulatory properties. Patients using TNF-suppressing agent are at increased risk of infection and reactivation. TNF-alpha inhibitors example, infliximab, etanercept given for any indication is found as a risk factor to develop tuberculosis. Humans with impaired IFN gamma genes are highly susceptible to severe TB disease. TNF may also contribute to deleterious inflammatory responses in patients with progressive disease. The tuberculoma. The hallmark of mycobacterial infection is the tuberculoma or granuloma. Granulomas are described by gross pathological appearance. solid or non-necrotic, caseous or necrotic, or end-stage cavitary. Depending on the degree of liquefaction, the caseum, from Latin, cheese-like, can be referred to as liquid soft or solid hard. It is thought that in solid necrosis, the mycobacteria are more efficiently contained, and generally less viable mycobacterium are found in hard caseum. If sufficiently large, the granulomas may drain their liquid content into the bronchial tree, releasing viable bacilli into the airways, to be aspirated into other parts of the lung or coughed up and transmitted. If associated with parenchymal destruction, it heralds the onset of lung cavities, where extracellular bacilli multiply exponentially. It has long been assumed that the granuloma formation serves the host in containing the bacilli and preventing bacterial spread, but it may also be exploited by the bacilli to proliferate. Indeed, many people have evidence of healed granulomas, without having experienced active tuberculous disease. On microscopic level, the tuberculous granuloma is an organized aggregation of immune cells and debris. It contains macrophages that have undergone morphological change into epithelioid cells, which form into zipper-like arrays around the necrotic center. They retain the ability to phagocytese mycobacteria. Macrophages can also fuse to form multinucleated giant cells and foam cells, which have high lipid contents, but their protective role is uncertain. Other cell types surrounding the granuloma are dendritic cells, neutrophils, B cells, T cells, natural killer NK cells, fibroblasts. Epithelial cells often are found in the outer layer of the granuloma. Mycobacteria are concentrated in the periphery of the central necrotic area. Thank you all. End of Part -1. Pulmonary tuberculosis. Learning pulmonology.